morning, everyone. We are going to continue our lecture series on health and well-being today by having John Steiner. He is the owner of Alamo Rehab and also Alamo Companion Services. He's also a licensed physical therapist here at the ARC. I've known John for 20 years myself, and I can tell you that John does so many good things in the community that aren't even mentioned. He does a lot of pro bono work for us. He's always willing to help. He rescues us at the 12th hour, sometimes at midnight, when a resident's coming back from the hospital, needs someone to stay with them. And I can tell you that if someone needs shower and bathing assistance and doesn't think they do, but we know that they are a trip and fall hazard, I can have one of John's caregivers come in a nanosecond. So what I'm trying to say is John provides so many services. He's truly an unsung hero here in our community, and has been here for how many years, John?
24, something like that. I've lost track. I had hair when I started here.
Yeah, yes, he did. I remember that. However,
I'm saying it's the ARC's fault, but
however, I can tell you that John's services are such an asset, such a benefit, and he and his team bring such value to the community. I often talk to many of my counterparts in other facilities here locally, throughout the state and nationally, and I can tell you that their therapy team doesn't even hold a candle to ours. So without further
most of my
ado,
therapy team, I'll just say, has been here like
yes.
10, 15 years, which is unheard of.
Yes, John's therapy team has been here. He has great retention, and I can't speak more accolades for him because I'd be going on all day. But without further ado, here's John.
I wanted to just visit with everybody a little bit. I'm going to take this off because I like to move around and everything. But I do have my cheat notes here, and I may have to put my glasses on, my old people glasses on, because I can't see that well anymore. I was going to say, no one here has that problem, I'm sure, but I kind of wanted to talk about therapy, but I kind of wanted to walk through the process of what goes on in therapy. I want to talk about, first I'm going to talk about healthcare and the process of healthcare, and then we'll move to outpatient. To talk about therapy when you come down to healthcare, okay? Specifically, it's what I call rehab, where you're getting therapy pretty much 5, 6, 7 days a week after a hospitalization. Okay, so when you're in the hospital, one of the most important things, if you are going to come back down here to healthcare, this is really important. For Medicare A to kick in and pay for everything, you need 3 midnight stays. Okay, really important. If you're there for 2 midnight stays, Medicare A is not going to kick in, which means you have to pay the room. Go ahead.
Okay, does this even include after surgery? For instance, I have a friend who's having knee replacement.
Mm-hmm.
She's only going to go to the hospital 1 day.
You have to have 3 days.
Oh,
Yep.
no.
Mm-hmm. Now, a lot of these surgeries have come, the technology and everything is amazing, and the recovery on them is pretty amazing. But if there's a problem or whatever, yeah, technically to come in, I mean, there's no technically. If they don't have 3 midnights, Medicare A is not going to cover it. So, yeah.
But saying that, with the 3 midnights, we have been working with PAM Health Specialty, which used to be Warm Springs. And if you do not get the 3 midnights in the hospital, they can come assess you and admit you to PAM, and you can get your 3 midnights there and then come back to the SNF here. And I do have those pamphlets and that information in my office for that.
Yeah, thank you very much. That's a great point. And we've actually referred quite a few people over to I still call it Warm Springs because I'm old, but yeah, Pan or Pam? Pam, okay. But yeah, and they have a new one really right over here, like across from Lowe's. So it's really convenient. It's not too far away from the Ark. If you have family members or your spouse, whatever's over there, it's not so far going all the way across the medical center. So that's really nice. And we've had people who've had issues here. They've come into healthcare, or I've gone to the cottage, and I'm like, oh, this person really needs daily therapy. Medicare B, twice a week, 3 times a week is not going to cut it, but they haven't had a 3-day hospital stay, or they went to the hospital turned around and sent them right back. So we've sent them over to Pam. And like she said, then that gives you the 3-day hospital stay so that you can come back here and under Medicare A in the healthcare center. Now, I'm going to say this, and I'm not saying anything bad about them, but this is just the way that it works. They're going to try to send you home. And they're going to try to send you home because it hurts their numbers and because it affects their reimbursement, as I understand it. So if you feel you need to be, if you're at Pam or somebody's at Pam and you feel, no, I really need to go to healthcare, I feel like I need to go to healthcare, you have to stand up for yourself and tell them that. Because if you don't say anything, they're probably just going to try to send you home. Would you agree with that?
Yes, and I work with them. If I know you're there or we help get you there, they will call me, and I've been working on making sure we get them back
Yeah.
here. That's usually the plan, and we know that ahead of time. So they've been working with us.
Yeah, they've actually done quite a bit better job here lately than say 5 or 10 years ago where we had that issue. Did you have a question?
No, I was just gonna say that all those options were not available. You have home health care, like after knee replacement, hip replacement.
Yeah.
If you come home, you can have home health care, your doctor
Mhm.
has to sign it before you leave the hospital or care.
Yeah, home health care is definitely an option for sure. But I will say this about home health. Home health is not anywhere near a replacement for daily skilled therapy if that is your need. If that is your need. And I'll get into the home health stuff in a little bit, but so remind me to circle back to that. So any questions on that? Okay, I haven't even got you to the Ark yet, and I'm supposed to keep it relatively short, but I've already taken a lot of time. But I want to make this point, so it's really important. And the other thing I want to mention, some of these hospitals, especially if they're really busy, they'll admit you into the ER, but you're not admitted. You're what's the term? Observation. And you may think you're admitted, but you're just being observed. So you have to be admitted. So that's something that you just need to be aware of. I know we do our best to try to make sure, yes, that they've had the 3 midnights downstairs. She does a great job helping us out too. Debbie does. It's a whole big team here working together. But you're there. You're your best advocate. So make sure the first day is not some kind of observation thing. They do that quite frequently. Okay. Now, I'm going to speak to some of you, and I will try to be as impartial as I can, which is not very good. Those of you that are on HMOs, pause for dramatic effect. I know that there's a lot of you people who are on HMOs, they love their HMOs, they think they're great. I hate them. I'm sorry, I don't mean to be rude, but I don't like them because I don't feel like they're watching out for you guys. And in my now some of you don't have a choice. If you're like on a teacher's thing, I get it. But if you have the option, and really Medicare and TRICARE is the best thing out there, TRICARE for life. But if you are on an HMO, there's a couple things you really need to know. If you're in the hospital, you have to be approved by the HMO, pre-approved, should I say, before you leave the hospital. And that pre-approval is usually initiated by the hospital and then sent to us. We need to have that pre-approval in our hot little hand, not somebody telling you on the phone, oh yeah, it's fine, we'll cover it, we'll cover it. Doesn't happen that way. And I'm saying this because we've run into this problem. We've had people come in, oh, well, they told me I was approved, and then they weren't approved, which means they have to pay for everything while they were there. Now, usually we find it out hopefully fairly fast, but, you know, so when you're in the hospital, if you're on an HMO, and the case manager should be the one to help you. Lucy, I don't know if you have anything you want to add to that, or Debbie, you have anything you want to add to that, but it had to be approved before you get here. Okay? Anybody want to add anything to that?
We've run into this issue quite a few times in the past 6 months, and I will tell you, to get pre-authorization is critical while you're in the hospital, if you're on that HMO. We have had residents come back and they were just flabbergasted that then they were going to have to privately pay for the charges incurred in SNF. So pre-authorization by the case manager is critical while you're in the hospital. If we find out that you are in fact on a Medicare Advantage plan, we do our best to try to hunt down what the provider is, and try to contact them immediately to see if we can get approval. But sometimes that process is lengthy and it takes time. And it's not enough time for the discharge to take place. So it becomes kind of a hornet's nest, if you will, in trying to get that authorization qualified for payment. So whatever you do, if you are on that Medicare Advantage plan, please, you know, knowing if you're going to go in for a procedure, get that authorization done while you're in the hospital, immediately while you're there.
Yes, sir.
I still get some medical journals, and some of the articles address Medicare Advantage. To summarize it, Medicare Advantage is for profit.
That is correct.
They respond to their stockholders and their executives. And that's being reflected in patient satisfaction scores and outcomes. It sounds awfully good, but that's the essence of their business model. I just bring that to your attention.
Yeah, and they sell it. They sell it hard, and they call people up who, oh, you get this, and this, and they don't tell you what you're losing. And in fact, just today, I don't know if any of you heard, apparently the Department of Justice is opening up an investigation on United Healthcare, which sent its stock tumbling down, but they are specifically investigating the Advantage program. I don't know any more details than that, but that did just happen this morning. Anyway, so yes. Uh-huh. I mean, they're going to promise, oh, you get this, this, and this, but again, like I said, they don't tell you what you give up. And that's kind of the catch. And, you know, it's kind of like when I was in college and they wanted to give me a credit card and I got a free t-shirt. Ooh, free t-shirt. Yeah, no, don't. Sorry, I don't know why that popped in my head. But real quickly, I'm going to go over kind of the difference between an HMO and Medicare if you're in healthcare under skilled. So Medicare is pretty easy. You have 100 days. And that is up to us as long as we feel we can justify it to Medicare. We've never had anything kicked back to my knowledge, at least in terms of being able to justify it from a therapy standpoint. So you have 100 days of Medicare. I don't have to submit anything. I don't have to do anything. And let's say you're here 100 days and you need a little bit more. Those of you that have TRICARE for Life, you can continue on daily skilled therapy under TRICARE for Life. Now, with them, every 30 days, I have to send in new paperwork. The good thing is that they pre-authorize it. So here, we're gonna give you 30 days. Well, then we submit it and they either deny it or they don't. So you're not in any danger of having to pay anything out. And we have had quite a few people use TRICARE for Life, people who are there down there in long term, and then also people who just need a couple of months extra because they had 1, 2, 3 things, 4 things happen to them, and it just took them 3 or 4 months, 5 months to go home. I mean, I wouldn't say that is. I mean, it sounds like a long time, but if you break a hip and then you get pneumonia and this, that, or the other, that's not unheard of. So that is the advantage. Now, in an HMO, like we talked about, you have to get the pre-authorization. So we get the pre-authorization, you come in, we're going to do the eval. We have to immediately send off the eval to the HMO, and they will determine how many days we get to treat you. So generally, and I'm not going to say that I'm an expert, but I've done this enough here and work with people enough to know, generally they give us 3 to 5 days, depending on your diagnosis. And generally we're having to send them notes every freaking 3 days, which is a huge pain. And then when they determine that you're ready to go home, they tell us, we're not going to pay anymore. Discharge them from therapy, discharge them from healthcare. Okay, so basically, the HMO is dictating your healthcare versus the physician, me, the nurse. I mean, and we have no say-so. Or, well, the say-so is you can stay and you can pay. Which doesn't,
Something I just learned is from a friend, she couldn't go to Pam because she had advantage. They didn't take advantage.
And that was the other thing that I'm glad you brought that up, because that was the other thing that I wanted to let you know. First of all, you may or may not be able to even come here. First of all, if you're on WellMed, you ain't coming here. They will not allow it. Well, I mean, you can come here, again, but you're going to be paying out of pocket for everything.
You don't take advantage here either.
We do have contracts with some advantages programs, but what we've also discovered there is, even on the other ones, like I think United is probably the biggest one that we've been dealing with. And there's 3 zillion of them too, which makes it almost impossible to, and again, I'm not going to tell you I'm an expert at all this, but generally the Advantage plans are going to want to send you the people that they have contracts with. So if you're on one that Debbie, do you know how many we have contracts with now? 2, 3? It's the biggest ones. We kind of took a poll, I think, who here has what, and we tried to get the ones that's going to encompass the most people. But with these plans, most of them are going to send you where they want to send you, which probably isn't here. Okay? Now, some of them will say, oh, yeah, well, and when they sell it, oh, yeah, you can go anywhere you want. Yeah, you can, again, as long as you pay. Which kind of defeats the whole purpose of, anyway. Or some of these, and you may not realize this, sometimes you can, oh yeah, we'll approve you to come here, oh, but you gotta pay a daily copay. You gotta pay a daily copay. And I know there's a yearly copay for Medicare and TRICARE, but it's just once. So, so basically, again, and to summarize, I won't beat this horse anymore. They're going to dictate your care. They're going to determine when you go home, even if we feel that it's not correct. Now, you can fight it. More paperwork, you got to wait. You can stay and continue, but if they deny it, oh yeah, you got to pay for that. So, and in the meantime, you're just trying to get better and go home and get better. So anyway, Debbie, did you want to add anything? I'm going to move on from that, but anything you want to add on that? Lucy, anything you want to add on that, or anybody?
If I understand you correct, as long as we stay with basic Medicare and TRICARE for life, we avoid all these issues.
That is, until Medicare decides they want to change things up. But yeah, right now, Debbie, would you agree with me? There's nothing better out there than Medicare and TRICARE for life. There's nothing better than Medicare and TRICARE for life.
It's the Cadillac of the world.
It really is. I mean,
Us civilians are very jealous of it.
absolutely, absolutely, yeah.
Yesterday, it was my understanding that at the base, there was a kiosk set up for Medicare Advantage. And there was a salesperson there. We must have had 5 residents come into our office yesterday. 3 of them had already signed up. And now we have to get them to disenroll. So beware and tell your friends that if they go to the base, do not stop at that kiosk, because what they're selling is not as good as what you already have. Okay?
And I know a lot of people have had problems when they try to disenroll. Is that a fair assessment too?
Yes.
That they don't make it easy. And you know what? And I'm going to be, and I'm the biggest capitalist out here. Okay, I really am. But it comes back to what this gentleman said. They're for profit. Enough about that. I didn't mean to go on I didn't mean to go on that long about it, but I just feel like it's so important that you know and that you're educated and you know what's going on, and go tell your friends. Yes, ma'am.
So, do I have this right? To come here, even with Medicare and TRICARE for life, we have to stay in the hospital for 3 nights.
3 midnights.
So, what if they won't keep us?
If they don't keep, first of all, that's you try to say, please keep me, and beg the doctor. A lot of them are aware of that, and most of the hospitals work pretty good on trying to keep 3 midnights. They really, especially the ones at BAMC and the Northeast Methodist, which are the main 2 that we go to. But if they don't, the other option that Lucy brought up is you don't come here, you go to PAM Rehab, which is a whole different type of facility than here. They have doctors on site, they do labs there. It's more of an acute setting than here. But you stay there usually 7-10 days maybe or so, and then that qualifies you to come here if you need that. Now, you may go over there and you're better and you can go right home, and that's okay too. But a lot of people who go over there end up coming to the healthcare here. But again, they're going to try to send you home. So if you don't feel you're ready to go home, you say, no, I'm going to healthcare. I want to go to healthcare. Again, stand up for yourselves. You are your best advocates.
Yes, and that's where I'm very helpful, is because when you're in the hospital, if I know you're there, I call every day to check on you. And sometimes it's a misconception that you are in healthcare, not in independent living. So once they realize that you're in independent living, they're going to take the 3 nights more seriously as far as getting you what you need or looking at other avenues. But most of the time, they think you're in healthcare, not in the independent living side. So if I know, I will work with them and help you make sure that you get the 3 midnights that you need.
What she was saying is that make sure that you tell your doctor, your case manager, whoever you are in the hospital, that you live in independent living, because a lot of them end up thinking you're in healthcare, that you live in healthcare, and so they're not as worried about the 3 midnight stay. But if you're in there, you need to make sure they understand, hey, I'm in independent living. I live by myself. I don't think I'm safe to go home by myself. I'm afraid to go home by myself. I want to go to healthcare, and I know you need 3 midnights. Now, don't be afraid to say it. Medicare is your benefit. You paid a lot of money in your whole life, you and your employer and the government and whoever else. This is your benefit. You have the right to use it. Okay? I'm sorry, I don't mean to sound like I'm preaching, but I guess I'm preaching. So. All right, any other questions on that before I move on? Okay. I'll try to move a little faster. So you're coming home to the Ark, and you're on Medicare and TRICARE. So they come in, usually you're brought in by an ambulance, sometimes you're brought in by a personal vehicle, but most of the time you're brought in by ambulance. And you're gonna come in and they're gonna wheel you into the room, and you're gonna be kind of bombarded with a lot of people, including me. You know, the nurses are gonna be there doing their assessments. You know, there's so much rules, regulations, things we have to do, and we're under time crunches to get them done, all by the federal government to meet the Medicare guidelines. And you're just tired from waiting for the ambulance to get there, and you just want to go to sleep. And then here I come in. And, you know, you're going to get 3 evaluations, generally speaking. Usually I'm going to be probably the first one in there from the therapist for physical therapy, but you will also have, while you're under skilled care, you're going to have an occupational therapist come in, and you will have a speech therapist come in. Okay? I'll start with speech. You may not have a speech problem, but speech covers a lot of other areas than just speech. Okay? So, and the main one that they do is if you're having any kind of swallowing difficulty. And then they also work on cognition. So they have these series of tests. You know, a lot of the people who come in don't need speech. They don't need it. But if they are having, you know, certainly anything neurological going on, they may have a swallowing problem. They may have a swallowing problem and not even know it. And the swallowing, and something's going into your lungs, which puts you at risk for pneumonia. We're required to do a cognition test, so please don't be insulted. When we ask you, could you draw this clock for us? We have to do it by Medicare law. So we do not think you're stupid. It's what we have to do. We have to do a cognition assessment. So that's usually after, maybe that will not be the day you get there. That will usually be the next day or the day after that. But PT and OT comes in there, and I'll be real quick. PT, in a broad sense, is from the waist down, OT is from the waist up, but we do both, you know. Generally, PT is working with strengthening the legs, we're working with walking, can you get in and out of bed, what is your activity tolerance, there's a lot of overlay between the two. OT, occupational therapy, has absolutely nothing to do with your occupation. I don't know where the name came from, but it has nothing to do with your occupation. It really has to do with activities of daily living. And a lot of people are like, oh, OT, I don't know. No, you do. You do need it, because OT works on very important things such as dressing yourself, going to the commode, cleaning yourself, pulling your pants up after you've gone to the commode, and doing it all safely and not falling. Okay? And, you know, when people come in, you know, some of these people, you're so debilitated, so we can't even get you on the commode. So, I don't know about you, but dignity-wise and everything, getting on the commode is kind of a big deal. And I'll just leave that at that. I'm not going to elaborate any further. But it is, you know, but it's all, everything in healthcare, it's about function. Function, function, function. Can you roll? Can you get out of bed? Can you come to a standing position? Can you walk? How far can you walk? Are you safe when you walk? Now we get this in I get this done in healthcare and in outpatient, where, can you walk? Yeah, I'm just fine. I don't have any problem. Have you had any falls? A couple. How many? About 15. Y'all think I'm joking? I'm not. But it's all about function, getting you back to your previous level of function. Because I'm gonna ask you that. We're gonna want to know, where were you before? Were you using a walker? Were you driving? Were you going here? Were you going there? Well, I've been having problems the last couple of months. Oh, okay. And then we do manual muscle tests. We test all these different things. But again, it all comes back to function, to getting you back to the point that you can go home. Now, most people tell me going, right in, I'm ready to go home. You just got here. And I know that there's no place like home, and I know you want to go home, and I want to get you there as fast as you can. But I get paid to be conservative. I get paid to be overprotective and paranoid. And most of my team's been doing this a long time, and we're not psychic, but a lot of times when people kind of push to go home early, they end up back. When you go home, I want you to stay home. I don't want you coming back down. And I don't mean that. You're welcome to come back down and visit and walk by, because you're probably not going to come in the door. Nope, got to walk real fast. I don't want to go in there. Get sucked into the vortex. Yeah, but it's all about function. So now that doesn't mean you have to be perfect to go home, but if you're able to do everything, but you do 3 minutes of activity and you're probably not ready to go home. It's there's the medical component of it all too, which I won't get into because that's a different component, but there's a lot of different factors to it. And so when we get there, you're going to have all these things, and then we're going to meet together with what's called the IDT team. And most of the IDT team has been here for quite a while. So you've got therapy, you've got nursing, you've got dietitians, you have the social worker, all this group of people. And we get together and discuss you. What do we need to go home? What are their, what are their limitations? What's going on physically? What are their labs? There's all these factors that go into it. And so then we will have about 5 days in, 7 days in, we're going to have a meeting with you and your family and discuss those things. Where are we going? How long is it going to take? And of course, again, we're always going to ask you, what are your goals? Okay, so you go through the therapy, blah, blah, blah. And as we're getting close to home, getting close, ready for discharge, at some point, we're probably going to want to do a home assessment. Now, so we will go, one of the therapists, maybe PT, maybe OT, to go with you to your home, apartment, wherever you're at, and tell you how to completely redo your apartment and redesign. No, I'm just kidding. Just kidding. We're not there to do that, but we are there to point out, hey, this rug may be a problem, okay? You know what, guys, I want you to move some of this furniture where it's a little wider, because your walker won't even fit through there. Anything safety that we see that might be a problem. Again, you can do whatever you want. I'm not there to tell you what to do. I'm just telling you areas of concern. The other thing that we're going to do over there is we're going to make you get in your favorite chair. We're going to make you get in and out of the bed. We're going to make you get on the commode, fully dressed, of course. And we're going to make you get in and out of the shower. We want to see how you do. Most of the time, these home assessments go just fine and there's no problem and you're ready to go. But every now and then we run across something like, we didn't see that. They're really having a hard time with, whatever it is. We need to continue to work on that. You're not quite ready to go. But let's just, okay, so we've done the home assessment, everything is good. So then, once again, you're probably going to have a meeting with the whole IDT team and discuss your discharge. We generally like to plan these things out because, again, it's not just healthcare. It's, Debbie's involved when you're going home and wants to know in advance. Lucy wants to know, do you need any supportive services? Do you need the caregivers to come in and help you with a shower? Maybe you're totally independent, but you just need some, or maybe you just want somebody there. We have those available to you if you need it. And it's not unusual. Somebody goes home and maybe for 2 weeks they have somebody coming in helping them shower, and then, hey, I'm doing great. I don't need anybody anymore. Great. Now, generally, when you go home and we talk about this in this meeting, we're going to discuss the two options of home health or outpatient therapy. Those are generally the two things that are going to happen when you go home, okay? Assuming you want to continue with some form of therapy. I mean, not everybody does, but most people continue with something. Again, it's covered by Medicare TRICARE. It's your benefit. You have it coming to you. So, home health. You've talked about home health. Home health has its, I'm not a huge fan of home health, but it certainly has its purpose if you need it. You know, if you're having problems maybe managing your medications and you need somebody kind of help you set that up. But home health's not going to go forever. It's generally going to go for maybe, 3 weeks, a month or so, ballpark, and then they cut you off. You know, now if you're with a VA, it may be a little bit different, but generally Medicare, they're going to cut you off at some point. They will not go on forever. There may be special cases that I'm not aware of, but generally here, they don't. But maybe you have a need, maybe you have a wound, and you need a nurse to come up and take care of that wound. That's certainly necessary. But just from a therapy standpoint, home health is very limited from a therapy standpoint. Most are going to come in with a few TheraBands and a bike, as opposed to the outpatient gym. If you've never been up there, please go look at it. We've got all sorts of torturous gizmos in the therapy department, and then we also utilize the wellness center across. I mean, we have so much more equipment. There's so much more we can do than home health. Again, that doesn't mean I'm not poo-pooing home health. It just depends on which one is appropriate for you. Okay? So, you're home and you've decided to do outpatient therapy. Okay? Now, when you're coming from healthcare, we'll have an order ready for you. You don't need to worry about an order. Okay, we'll get it from Dr. Story, whoever, hey, PT evaluate and treat. So we'll have the order. For those of you that aren't in healthcare and you want to come to outpatient therapy for whatever, your shoulder's bothering, your neck's bothering, whatever, we still have to have an order. We have to have an order from a physician, nurse practitioner. We have to have an order from somebody. So the first step, if you want therapy as an outpatient, is to get the order. Again, if you're coming from healthcare, we'll have the order. Okay. Once we get the order, we have it, we'll set up an evaluation. Generally, Ramil's the one doing the evaluations upstairs. Probably most of y'all know Ramil already. He's been here quite a while, and he's an amazing therapist. When you come for that first time, there's some paperwork to fill out, but he's asked me to make sure that when you come, you bring your identifications, you bring your cards. Please bring your Medicare cards, or if you're on an Advantage plan or whatever plan you have a secondary insurance, please bring your cards, and even maybe bring your military ID so that we can make a copy of them and put them in the system. Because what we have had major issues with is we go into the system and the cards aren't there. We've had somewhere where we go in, the Medicare number's not even in there. Okay, so but once we do that, we need to be able to do that, because we're going to run a check on Medicare to tell us whether you have Medicare or, we have an HMO. We got to get that pre-approved, which is a whole nother process. It takes a while longer. Also, too, we'd really like you to make sure, and Debbie, tell me do they go to you or finance? I get confused on this. If you make sure that they have your updated cards, make sure in the system, make sure that they have made copies of it. Is it finance or is it you, Debbie?
We take the cards.
You take the cards, okay. So just make sure that you go and that your cards are up to date in the system, and that will avoid a lot of, it would help us out tremendously, okay? So, but much like up there, we're going to go through, and Ramil's going to do an eval. This is a different level of therapy. It's totally different than the therapy downstairs. Because I hear this all the time. Well, they work me a lot harder upstairs. Yes, they do. But right now, I just want you to be able to sit up on the side of the bed without falling down. Okay? It's a different level. It's the next step up. Okay? Because we know you can function now. Now we want to work on that high level balance. Or maybe we want to, specifically target your pain, whatever it is that's going on. It's truly, like I said, it's just a whole different level than what we're doing downstairs, okay? So he'll go through, he'll do the eval. He may run you through a series of tests. We've got all these therapists have all these different tests. We want to see how fast you can get up and go. We want to see you turn around, do a little dance. See if you can stand on one leg. I know all these seem a little silly, but they tell us something. And that gives us kind of a starting point of objective data. And then 30 days later or at your discharge, I want you to do it again. Okay? And that tells us where you're at. Have you made objective improvement? Whereas downstairs, the improvement is measured in, can you get out of bed? Can you stand? Can you. So it's a lot different. And then, of course, we also have OT up there, which also does a lot of the same things. Maybe they're working with shoulders or whatever. And it's not unusual to maybe do 30, 60 days of PT as an outpatient. And if you need to continue, then we're going to switch you over to OT so we can draw it out. Because Medicare will not pay therapy forever upstairs on outpatient. There used to be a cap, a hard cap. Now they've done away with this cap, and I'm going to use the word, it's like this quasi-moving cap, but they are tracking it. And if they see or think that we're misusing it, they will audit us. And we have been audited before, a fairly big audit, and we did 100%. We were good. And that's a real tribute to those guys upstairs, not me. But that's, we'll kind of do that because for whatever reason, PT and speech come from the same pool and OT comes from a different pool. I don't know, it doesn't make any sense to me, but that's what we have to work with. So, we're going to manage your Medicare correctly. We're going to give you what you need, but we're not going to, draw it out and misuse the system because those are our tax dollars. So you've gone through outpatient therapy. Your get up and go has gone up and went, and you're doing great. And you don't really need us anymore. So what they're going to do, and they always do, is they set you up on the home exercise program, which I know all of you do. And then the other thing that we will do is we're going to take you across the hall, and you're already going across the hall, working on machines and different everything. So you're going to be familiar with the program over there already. Okay, but we like to refer you over there so when you get done with us, you continue over there. Okay, so we're going to tell her what's going on, and so that she's aware. And I don't know if she makes harassing phone calls to where were you today for your exercise program. I don't think she does. She doesn't do that. No. Okay, good. Yeah, that would be rude, wouldn't it? Yeah. But we do. You have it available to you. And then, of course, if you have a question or a concern or you're not sure about something, all you got to do is walk right across that hallway and ask us. Just because you're not on our caseload, whether it's downstairs, upstairs, or whatever, you're all residents at the ARC. And as far as I'm concerned, every person who lives here is my patient. and sometimes even family members. Hey, we're here for you guys. And I'll just say this about my staff. I can tell you this: they all feel extremely blessed to be here, and it's because of you guys, and that's why all of them have been here so long. What other questions everybody got?
I just want to compliment whoever is buying the new equipment for the gym, because I take Bruce to the gym now, and there's equipment he can drive. He can drive up to in his wheelchair. The equipment.
The seat turns around. Mm-hmm.
And also the chairs turn around so he can transfer on the other equipment so he can stand up, sit on it. And I'm glad to see that because some of it is just not.
It needs to be accessible
Yes.
as much as possible. Debbie, do you want to say something?
That equipment is all coming from resident donations and resident council, one-time buys.
So I guess we should be thanking all of you for that wonderful equipment. And as therapists, I promise you, we do thank you for all that wonderful equipment, because for us, to be able to go in and have all these things that we can choose from to provide therapy, is a wonderful feeling.
And that's what Warm Springs has, so that you can use your
Yeah.
wheelchair.
Well, that upstairs gym across the way, it has more than what Warm Springs has, because again, it's a different level. Yeah.
Now that you are getting
Yeah.
the equipment in, it makes it nice.
Mhm.
I'd like to say, if you need rails for your bathtub or your shower or something, make a phone call and they'll be up that day and put rails in. Because I know our bathtub has all the way around our shower, next to the toilet, next to the wall.
Thank you for bringing that up, because when we do our home assessment that I talked about, I didn't mention it specifically, but that's one of the things that we're always looking at. And hey, I think you should put a rail here. Again, it's your home. I'm not there to tell you what to do, but from a safety, and a lot of times maybe let's just put one more rail on the outside, the shower where you're getting in, or whatever it is. And then we'll put, if you're downstairs and healthier, we'll put that work order in for you and try to get it done. Yeah, I'm a big fan of rails. So, anybody got anything else?
I comment that a while back, a couple years ago, I had a pinched nerve, and my primary care said, "We're going to send you to physical therapy." She's like, "Oh God, we got to find you a physical therapist. Where do you live?" I said, "Oh, I live at the Ark." "Oh, that's wonderful." She was thrilled because she had a lot of experience with writing prescriptions for the Ark and the response. She loved you guys. She was so happy that she didn't have to go trying to find somebody for me somewhere else.
Yeah, we paid a lot of money for that. I don't know, Debbie, did that come out of me or you, or I don't know what fund that came out. No, I'm joking.
It was from NEMA. The NEMA folks have.
Yeah.
But they love you.
That was a joke. So anybody who didn't.
No, John, I just want to thank you for a very informative presentation and reiterates a lot of things we need to be aware of. My wife has a lot of health issues, went through 2 hip replacements, other medical things, and she went through everything you're talking about. And she was up there. She's not here today because right now she's up there doing the post-therapy, means the at-home stuff. So you can go through physical therapy, occupational therapy, have the walker, the wheelchair, and she's been through all that. But unless you take control of the things after you get out of that and do some home stuff, you're going to regress. You're going to fall back into some bad habits. So she's up there now following the plan. Thank you.
Thank you. No, that's a great point. As the therapist, we play a lot of different roles. Sometimes I'm an educator, I'm a teacher, sometimes I'm a cheerleader, not a good looking cheerleader, but I'm a cheerleader. I'm a motivational speaker. I also move furniture down in healthcare quite a bit and fix TVs. But we do a lot of different roles, and sometimes most important roles, we're just listening. And, sometimes, unfortunately, people don't get better. And, we're, talking to the families, we're talking to spouses, and it's not always easy. But we play a lot of different roles, but ultimately, it's up to you what you want to get out of there. Again, I can teach you all this stuff I can do, but you know what? I can't do it for you. I can't do it for you. If I had a magic wand, I would use it in a heartbeat and make everybody better. But I don't have it. And so, you know, and I have this loving conversation sometimes with folks. Hey, listen, you got to give me some effort. You got to meet me halfway. I can't do this for you. So, to your point, you're going to get what you put into it. Now, obviously, there are certain people who have physical limitations that they can't do it. You know, and for those folks, hey, I'm here. I'll give you a shirt off my back if you can't do it. But if you can do it, you got to try. And the number one word I'll leave y'all with is move. I joke around, you know, I took a lot of student loans to learn one word, move. Oh, but you don't understand. I have move. Unless you have an acute fracture, then don't move. Go to the hospital. But for most everything, move. All right, guys, thank you so much. I hope I've been giving you some ideas and hopefully really educated you on the HMO stuff and the hospital stuff. And so if you do come into healthcare, don't be scared. We're really nice folks down there, I promise you. So, all right, guys, thank you.